Good morning or good day to all of you. It's time for us to start the IOMP webinar for this month. The webinar title is very interesting. The use of AI to improve access to high quality radiation therapy treatment planning in low and middle income countries. I am very much grateful for the excellent speakers we have lined up for this webinar. I also like to welcome the audience worldwide. You're all in different time zones. So my name is Mahesh. I'm the Science Committee Chair for IOMP. And I also want to thank Dr. Magdalena Stoa at IOMP, who is the Secretary General, who is running the whole show behind the scene here, and also Dr. John Damalakis, who is the IOMP President, for inviting me to moderate this session and organize this session. Couple of things, logistic question things. I welcome all of you to insert questions in the Q&A section and not in the chat, because the chat will not be followed. It will be only the things in the question and answer I will compile and will be responded later. The way we want to do is like, we want to have the three speakers speak one after the other, and then hold all the question at the end, which I will moderate to ask the respective speaker to answer this question. Again, I also want to remind the audience this webinar has a credit available. It will be available for those who attend the webinar at the end. Plus, within 24 to 48 hours, the recording of this webinar will also be available at the IOMP.org website. I can search IOMP School Webinar Recording and you can search. So, without delay, let me introduce my first speaker, Dr. Laurence Court. Dr. Laurence Court leads a team who are focused on development and clinical deployment of AI tools to support radiation therapy teams in low and middle income countries. Their flagship product is the Radiation Planning Assistant, which has now received the FDA 510(k) clearance and is currently starting a clinical use in South Africa. So I welcome Laurence Court. He will be followed by Barbara Marquez. She is a PhD candidate at the University of Texas MD Anderson Cancer Center. Her research leverage artificial intelligence to improve peer review of CT-based contours. She's going to talk about the quality control necessity for these things. Followed which will be Dr. Chris from South Africa. He's the head of the medical physics division, and he leads a team of 5 medical physicists, and he's going to talk about the implementation of this treatment planning in his center. So let me start with Dr. Laurence Court. Welcome, Laurence.
Hello, everybody. Thank you for that introduction, and thank you to everybody for coming to listen. This is easily the biggest, well, basically the most people I've ever talked to at one time, I think. So let me share my screen. Is my screen being shared?
Yes.
Yes, good. Okay, so I'm going to give the introduction to the Radiation Planning Assistant and our efforts to create these tools to improve access to radiation therapy. Barbara is then going to talk about some research into automated QA, especially for contours, and Chris is going to talk about implementation questions. Conflicts of interest. So the learning objectives today, hopefully at the end of this hour, you'll all be able to describe how AI is likely to improve access to radiation therapy, high quality radiation therapy across the world. Also understand that AI can do some great stuff, but it does introduce some risks potentially, and so we have to understand those and think about ways to reduce them. And also, you'll hopefully understand some of the challenges in implementing these tools into clinical practice in LMICs. There's just a couple of motivation slides. So as I'm sure most of you know, there's a severe lack of radiotherapy access in LMICs. This map here is one of the many maps that are out there in various publications showing. This one shows the percentage of patients who could benefit from access to radiation therapy who actually have access, and you can see that in many countries it's less than 50%. And it's estimated that by 2040, 70% of the annual cancer cases will be in LMICs, but less than half of those patients have access. And it's not just access to radiation therapy, it's access to high quality radiation therapy, by which I mean things like VMAT. There was a study, a survey of African centers a year or two ago where they showed that only about a third of those centers were using these VMAT or IMRT type treatments. And so if that's not compelling enough, it's estimated that closing this gap could save nearly 1 million lives per year. Now, as I'm sure you all know, there's lots of reasons for this, but if we're going to do anything about it, we need to train an awful lot of people. There's estimated shortfalls of around 50,000 radiation oncologists and medical physicists. And so we can't train that number of people. And this is the basis of our work, that we want to try and do something to change the way our workflows are, our current workflows, so that we can scale our efforts to treat more patients. You'll see on some of my slides, there's QR codes. If you take a photo of those, that'll take you to the reference. They're all open access. So hopefully that'll help you if you want to look at the references. So this slide is meant to give a big overview of the radiation therapy treatment planning workflow. It doesn't show all of the little steps, but it shows you the big picture. So we start with the diagnosis and evaluation by the physician. That's the decision to treat. We take the CT scan. The physician prescribes the dose to the tumor and to the normal tissues, and then they do all that contouring that they have to do. They contour the targets and the normal tissues. So that's the first row. Once they're done, they pass that off to the planner. It could be, if you have dosimetrists, that's great. If not, it's somebody else, maybe physics is doing that role. And they then do a little bit, some more contouring possibly, and decide on beam arrangements, do the optimization. And when they're done, they've got the best plan that they think they can achieve to go back to the physician. And then often there's this iterative process on the third row here that is where eventually we come up with a plan that the physician approves. And then there's a whole series of QE. There's physics QA, there's physics QA, there may be some peer review, and other processes. And so there's several things you can see here. One is there's a lot of big steps, and the other is there's a lot of handoffs, and all of these things do cause delays. Luckily, though, this is 2024, and a lot of these steps are perfect for automation using various forms of artificial intelligence. So what I've done here is I've just drawn around the steps that are being repeated or can be performed by artificial intelligence. So the contouring, many of you may have seen, there's a lot of vendor solutions out there right now for automatic contouring. That's mostly normal tissues, but some target work is coming out. And then the planning as well. So there's a lot of publications. This isn't quite prime time in most cases, but we're going to talk about that. But definitely the planning process can be automated. And what we found is if you use these AI tools to automate contouring and planning, they're extremely consistent, which means the third row is much reduced. The need for these iterations is reduced. And then finally, quality assurance. Hopefully one of the points that will come across here is that even if you did manage to automate all of these processes, you still need the physics and physician QA at the end of the process for safety. But you can have a lot of benefits in terms of AI supported quality assurance. Okay, so how much, that shows the different steps that can be automated, but how much can we automate in a single step? So there's different levels of automation that people look at. There's task level automation, where we take a single task and automate it. An example of that would be IMRT optimization, or automatic creation of field in field, things like that. So that's essentially a single task. So that can really help out, but doesn't necessarily make a big difference to your overall workflow. Semi-automation with editing, that's where we've got like one row of that figure on the previous slide is automated. And that's an example of that would be automatic contouring. So you're helping one person's task, but that doesn't really affect the handoffs between different people. And the handoffs are really where workflows can get slowed down. And then the third level of automation is full automation with review. So this is where we're trying to aim. So we take the CT scan, we automate the contouring and the planning in one single step, where you need people at the start to tell the computer what you want. You need people at the end to check it and make sure the computer did what you wanted. But you've got real end-to-end automation that can help speed everything up and help reduce handoffs. And then full automation would be the situation where you take the people out of the loop, and where that's decades away, if ever. So really, the way this is heading, I would say, is to have this full automation with review. And if you can do that, this is what your workflow then starts to look like, where you've got your CT scan and prescription. You still need people for that. Then you get automated contouring and planning, and then you have final review by the physician and a bunch of physics and RTTQA. This can give you a gains in efficiency of several hours of physician's time. Think of all the time they spend contouring and reviewing plans, and then not a lot of time saved for the treatment planner as well. And there's also probably the main gains in efficiency are these reduced handoffs. There's also potentially gains in quality and safety, so improved consistency of treatments between institutions, improve quality of treatments potentially depending on the experience of your team, and then reduced handoffs. Handoffs are always a risk. When I do something and then I give it to somebody else, there's a risk that I don't communicate that properly. If you can reduce those handoffs, you can reduce risk potentially. Okay, so is it just talk, or can we do it? This is a little personal test for you. There's no prizes. I'm not going to travel the world and give you all awards or anything. But which of these contours were generated by a computer? One of these was hand drawn. One of these was generated by a deep learning tool that we use in our own clinic. It's used pretty consistently for sort of 30 to 50 patients a month. Reminder that the QR code is the paper. So it's the one on the left was generated by the computer. And you can see really there's slight differences in how some of these structures were drawn, but really they look the same. And the point I want to make here is, this is quite a difficult part of the upper abdomen, quite difficult part of the body to contour. It takes a lot of time, a lot of slices, these might look a little bit different, but clinically these differences are meaningless. And our physicians, in our institution, it's the physicians who draw these, and they tell us it saves them about 30 minutes per patient. We've done several timing studies to look at this, because one of the goals of automation is to save time so we can focus on more patients. This is the results from a study for head and neck, where we had dosimetrists contouring all of these structures. In our institution, it's the dosimetrists draw these structures. They contoured them from scratch, and they also used automatic contouring and then made edits to make them look as perfect as they could. And you can see that if you contour all these structures from scratch, it takes 50 minutes, which actually, thinking about it and how many structures there are, that's quite fast, I would say. But if you do it automatically and then do some editing, it's sort of 12 to 15 minutes per patient. So that's a huge time savings that can allow us to work on more patients. It's not just timing, it's also consistency and quality. So this is just an example drawing the heart contour, where the manual contours are in orange. These are 3 different patients, and the auto contours are in pink, and then the green and that's that cyan color, and the other different structures in the heart, and the purple is the pulmonary artery. And you can see that the manual contours, the superior border tends to vary quite widely. That's a difficult thing for people to do, but automation can help keep that consistent. That's just an example. This is true of other structures as well. Okay, so that was contouring. What about planning? Here's another test for you. Make sure you guys, well, I guess you don't need to worry about being awake. We do. It's 5 in the morning here. But this is one of these, same patient, obviously. One was This is a VMAP plan, was created automatically. One was manual. Which one is which? It's the one on the right. So the one on the right was automatic. You can see they basically look the same. The one on the left was the actual original clinical plan. When we showed this to the physicians, they had a slight preference actually for the one on the right because there's less spread of the dose out from the target, but really they look the same. So the point here is that the automated plans can do just as well as the manual plans. So AI does improve plan quality potentially. So we did a study where we had automatic head and neck plans, and we showed them to radiation oncologists from different institutions. We were a bit worried that different people from different places would have different opinions because that's the way things usually work. And so we had 14 radiation oncologists, each from a different institution. This was at a Astro head and neck symposium. And they scored 88% of the auto plans as clinically acceptable without edit. So that means those you could have just used as is. And in more cases than not, they actually preferred the auto plan. It's not just plan quality, it's also consistency. This is one of my favorite figures from a paper. It's from UC San Diego, University of California, San Diego, where they introduced knowledge-based planning into their clinic. And on the figure, what you can see is that for different structures, the sort of white shaded area is the pre-knowledge-based planning, and the gray shaded area is once they introduce knowledge-based planning. Each dot is a different patient. And there's a couple of things you can see. One is that the average doses to those structures goes down. So you can say that that probably means that the plan quality is going up. So you've improved quality. And also the variation from patient to patient is reduced. So that's implying that you've improved consistency. So AI in this case, or has improved plan quality and consistency. Also saves time. This is work from Toronto, Tom Purdy's group. And so they had the regular manual contouring process, but then introduced auto planning. They do a lot of this there at Princess Margaret. And so the top three bars are the human generated process. And you can see once you go down to the machine learning generated plans, the contouring time obviously doesn't change, but the overall time in terms of contouring plus planning is significantly reduced, as is the time, the total time, which includes the review. So you've really made a big difference. But you can see that, that huge time difference. That's not just somebody sitting there doing the planning the whole time. There's obviously sometimes it's just sitting on someone's desk because they're doing multiple tasks at once. So this can really help with getting patients through the system. It's not just those complex plans. That previous slide, I forgot to say, that was for prostate. This is some data from Tanzania, where they had their own patients and ran them through a process that we have developed to automatically contour the CTVs and normal tissues for cervical cancer patients, and then to define the beam apertures. So they ran 30 of their patients through and had 2 radiation oncologists score them. There was only one patient that didn't work, and that was because the scan length didn't go superior enough, and so the AI couldn't understand the anatomy properly, and so it wouldn't give an answer. But all the others they considered to be used as is. And the great news, so that's quality. And then in terms of timing, the great news is, nobody had to do anything for the contouring and the planning, and it took the physician 6 minutes to review the contours and the plan together. So this is the team down at the bottom, the team from Tanzania and from our place. Okay, here's another test if you're starting to nod off. So here, which of these was generated by a computer? Here is prostate plan. You can see prostate, seminal vesicles. One of these is a manual plan. One of these was manual. One of these is by the computer. Okay, so this one was the one on the left. The difference here, well, the point is the same as the point I'm making in all of these, I guess. The differences are not that important. But the other thing to note is this was a real end-to-end process. So the one on the left, all the contouring and the planning was done automatic. So all we had to do was tell it the prescription. The one on the right was manual contours and manual plans. So there are some differences that you can see in these contours and dose distributions, but they're not clinically meaningful. But once you start automating everything, you have to think, is it really realistic? You're reporting the dose to the automatic structures, but what does that mean in terms of the real structures? Because the automatic structures might not be quite right. So we've done a lot of work looking at that and what is the significance of the edits that people make. And the good news is that for VMAT plans, because you're trying to avoid these structures, really, if you plan on automatic structures, you get the same answers as if you planned on manual structures. And there's a couple of the results are shown here for head and neck cases, where the x-axis is the dose to the automatic structure, and which would be the reported dose. The y-axis is the dose to the clinical structure, which would be what you might say is the true dose. But you can see there's excellent agreement between the two. But that's great. So what I've said, everything I've said up to so far is what you read in all the papers. Oh, AI is amazing. It's going to solve the absolute everything for all the world. Of course, it's not. That's the rosy tinted glasses approach. There is some risk. There are some things we need to think about. If you think of images like this, we've all seen images like this. If that gets to your treatment planner or your contourer, you're gonna it's going to make you think a little bit. You're going to have to take a different approach to normal. You might ask for go back to the CT. You might have to change your beam angles, do some overrides, all sorts of things. If the computer doesn't know that, it might not do anything. It may just give you a plan. That's the risk. So it could just give you a plan, which you can imagine not going to be that great. And so that's potential risk. Of course, there's risk in everything we do in radiation therapy. This is a figure from Task Group 100 from AAPM showing the sources of potential failure for IMRT radiotherapy treatment. And you can see what's interesting here is that, okay, hardware and software failures, which is what us as physicists tend to think about, they're there, but a lot of these are related to us, the people. Do we do something incorrectly? Were we not trained properly? Did we not have proper procedures? Did we not communicate properly? Things like that. So there's plenty of human-related risk that we need to reduce when we're designing our processes in radiotherapy. Once we introduce AI, you might say, oh, you've taken the person out of the loop and your risk is much reduced. Well, that's not necessarily the case. There's still plenty of things that can go wrong. And even once you introduce AI and you say, oh, I've automated everything, there's still people involved. So you still have user error potentially. And you can see the figure on the left is the cause of all AI specific failure modes. So this is the failure modes that we looked at when you introduce AI. Users are still an important part of the process, so they still can be the cause of some errors. On the right-hand side are the cause of the high-risk errors, high-risk failure modes, and you can see operator errors right there. There's a few other errors that we're not so used to, or error types like automation bias. So now what that is now we have, if you think now we have these auto contouring tools, they're actually really good. It's not like 5 or 10 years ago where if you automatically contoured something, the only thing you knew was that you were going to have to make edits. That's not the case anymore. You might, in many cases, it's just right. And so you might be tempted to say, oh, it's always right. I don't need to check it. That's what we call automation bias. And that's when things can go wrong. And then there's other things. There's software error. It doesn't always get it right. Off-label use. That's like if you had an automatic contouring for cervix and you said, oh, I need to contour a prostate patient. Or you had like an adult auto contouring model. And you said, I'm going to try it on my pediatric cases. When you're trying your tools on things that they weren't developed and tested for, you can get some unexpected results. So there are lots of things you can do to try and reduce this. A lot of the ways to improve safety comes in your design of your user interface. You can make sure that you don't ask unnecessary questions. You can limit the doses that you can put into your prescription. I'll talk about that in a second. Have verification checkboxes. Make sure that you have people approving things at appropriate moments because we're reducing the amount of effort per patient, but you still need to have people in the loop there to make sure that everything is going appropriately. And then automated QA, which is what Barbara is going to touch on in her research presentation in a few minutes. This is just one example of where a simple user interface can help you reduce errors. There was a case reported from Royals where there was a patient who was prescribed to 300 centigrade times 10, but someone somewhere made a transcription error and added a 0, so the plan was calculated for 3000 centigrade times 10. Now you'd think, oh, how would that happen? Well, it did happen because they reported it and they thought it was significant enough. They wanted to let everybody know. It was approved by the radiation oncologist. It actually, from what I remember, it got to the machine, but no one was treated. The therapist, thank goodness, realized and stopped that. But you can just prevent this from happening in the first place by having limits on the boxes in your user interface, so you can't put in doses like that. And that's the approach that we've taken. Okay, another test. Another 2-dose, same patient, 2-dose distributions, displayed a little bit different to the last one. It's more of a color wash type approach, but you get the point. And which were generated by a computer. Give you a couple of seconds. Again, there's no prizes except for, like, you can just feel proud. So in this case, they're both generated by a computer. But what's the difference? So the one on the left is a complete plan with all the dose and also the machine parameters, MLC positions, all this sort of stuff. And that's a real plan. The one on the right is not a real plan. It's just a dose distribution. There's no associated MLC position. So what's happened is we've used AI to predict what the doses should look like. You might be thinking, well, why would you do that? Well, there's several reasons. You could use the one on the right for knowledge-based planning to guide your optimization. That's one thing you can do. The other thing is you can use the one on the right to QA the one on the left. So you can have AI-based peer review or plan quality evaluation. And that's the direction that we're going, because so you can have one AI system creates the plan and another one verifies it. And this is just an example where that might be useful. And so where we've got the clinical dose on the left, and you can see that whoever did this was pushing the parotid and the cord a lot, and you ended up with that sort of sticking out bit of the dose. And the predicted dose shows you didn't need to have that. And so you could imagine having a process where you automatically compare and flag this. So I'm talking a bit more futuristic now, but this is definitely the direction that these things are going. And there's lots of ways that you can use AI to perform quality assurance and really support this process. We have built some of these tasks into the radiation planning system, but I would say it's pretty early days. And Barbara is going to be talking about the automatic contouring QA in a couple of seconds. But just some examples here at the top, you can see this is a case where we had the patient was contoured twice by different algorithms. You can see if it agrees, then we can probably say that is a case that the contouring was successful. When it disagrees, you can flag that to the user. In this case, the surgery had caused one of the algorithms to get confused. So we've got some disagreement. We don't necessarily know which one is right, but we do know one of them has to be wrong. And so we can flag that to the user for verification. Oops, yeah. So how do we take all of this and make it accessible and useful? So the radiation planning assistant is our tool where we've taken what we've done in our own clinic in terms of contouring, added some planning, and then put this into a web page. The idea is that the user uploads their CT and fills in a form to tell us the prescription and some more information about what they want to treat. The tool then creates the contours or the plan, which the user then downloads to their own planning system, recalculates for their specific LINAC. Each LINAC can be slightly different depending on a variety of things. And then that enters their clinical practice. And so we have this working. It's out there, and we've gone live in South Africa, which is what Chris is going to talk about a little bit. This is just the results of clinical acceptability. So, ultimately we got to create things that the physicians like and think of appropriate for their patient. So we went through all the different processes in the radiation planning assistant, had them reviewed by physicians. We had a minimum of 3 physicians for each approach. In total, we had 31 radiation oncologists from 16 institutions, 5 countries, who are trying to make sure that we're accounting for variations in local clinical practice and things like that. And overall, in most cases, you've got sort of 80 to 90% are use as is. In some cases, like post-mastectomy breast, the use as is rate is lower. It's closer to 50%. But we did do a study to look at, well, if it's not use as is, how much time does the editing take? And the editing we found for those cases take about 10 minutes. So if you think to do a full tangents and superclavian field in field plan can take a couple of hours, if you could just automate that and spend those 10 minutes making the automatic plan acceptable for treatment, that's still quite a large time savings. This is our milestone, so I'll just go through this quickly, but basically the key points are we've been doing this for a while. Everything takes longer than you think. We got FDA 510K clearance 2023. Our hospital also announced in the same year that we're planning to provide this for free for institutions that can benefit from it. We have a quality management plan. There's a variety of things that you have to have in place if you're going to go through the FDA. So you have to be rigorous. You have to have risk management, quality management, all these sorts of things. We got legal approval for South Africa earlier this year, and we are currently live in 2 hospitals with plans to move to additional countries moving forward. So it's all going to, it isn't like we're not going to suddenly scale to everywhere. Unfortunately, there's each country we have to go through a process, but that's our plan. So thank you for listening. Thanks for inviting me. I know we're taking questions at the end. So I'm just going to stop sharing and pass to Barbara. Thank you, everybody. Over to you, Barbara.
Thank you so much.
Welcome, Barbara. I just want to welcome Barbara. She's a PhD candidate with Dr. Laurence Court, and she's going to talk about the QA-related one, which is a very essential for any of the AI to be successful. Go ahead.
Thank you. Yes, so today I'll be talking about risk mitigation and deployment of auto contours to clinical practice. These are my disclosures. So like we heard before, auto contouring has brought about unprecedented gains in the domain of radiotherapy. And this was with the premise that we are providing time savings and consistency. And we know auto contouring solutions span both commercial and in-house. So we have Protege AI by MIM Software, Radformation's Auto Contour, Limbus AI, who's also a Radformation company, offers Limbus Contour. And then we have groups like ours, the Radiation Planning Assistant, the Maya Laboratory, which is run by Dr. Steve Jang at UT Southwestern here in Texas, and the ROSA ML Research Group led by Dr. James Lamb at UCLA, for example. And all of these, whether commercial or research, are going to have a similar portfolio of challenges during implementation for reasons that we'll discuss. So as with any new technology, implementing this auto contouring safely and effectively to clinical practice is going to require new QA procedures. And in order to do that, we need to characterize the unique risks that auto contouring will bring both within its own ecosystem and as an integrated piece of the greater radiotherapy planning workflow. So when it comes to risk management, we have some tools to rely on, and one of those is failure modes and effects analysis, or FMEA. In our lab, we've already run a sizable and comprehensive risk profile of the Radiation Planning Assistant using FMEA. And we use our results to actually modify our user interface and training tools to reduce risk when people use our automated tools. In this analysis, we learned that most errors can actually occur at the contour editing, reviewing, and uploading stage. An example of this could be like a software error where our auto contouring tool segments a target incorrectly or requires minor edits to be clinically acceptable, but the physician doesn't properly review the contours or doesn't detect the error because it occurs in a small region that can go unnoticed. And so in characterizing the failure situations that were identified in the previous graph, we learned that most failures occur due to operator error and automation bias. So operator error means any accidental input, like clicking a wrong button in our service request or typing incorrect information. And automation bias is then the tendency of humans to depend too heavily on software tools and inadequately examine the output, like the contours. So you can imagine how this can affect the proper use of our auto contouring tools. And so in reflecting on this risk characterization within auto contouring, we need to remember a few key points. First is that any AI solution as it currently stands is mimicking the performance of some gold standard library of expert delineations. But no matter how carefully you curate a dataset, there can always be suboptimal training points that affect model performance. The second thing is that these training datasets could never fully encompass the range of patient anatomies in clinical practice. And so some challenges can include things like the auto-contouring not seeing surgical resections or hardware and having trouble contouring that. And finally, we have talked about validating and deploying these solutions, whether they be research or commercial. We have to consider the quality of evaluation metrics and whether they are truly representative of clinical acceptability of auto contours. And we'll review those evaluation metrics in the next section. So because of what we've learned, there are some special considerations to account for when designing a robust QA system that can effectively mitigate new risk from auto contour use. The first is that manual verification of auto contours can actually severely undermine the gains that we're getting from this time-saving tool, so an automated solution would be better suited for this task. The second is that the solution needs to mitigate the automation bias that we previously talked about. So this includes both reducing over-reliance on the auto contours and failing to review them altogether, while also encouraging the use of this automated QA solution as a decision support, but not a decision-making tool. Finally, we need to consider that the system should exhibit a high sensitivity to errors, for example, in target volume auto contours, because the cost of missing a faulty target contour is high on risk to the patient. So we also want to make sure that the QA tool minimizes alert fatigue and does not provide more work for the user by flagging too many false positive cases, for example, too many false positive OARs to review. So we need to maintain a high specificity when it comes to that. So now let's talk about the methods that make automatic QA for contours possible. Some of the earliest work in quality assurance involved the different ways of evaluating structures geometrically. So whether that be in paired comparison with a gold standard manually derived contour, or as part of a greater statistical approach to compare one contour's geometry to an atlas of acceptable geometries. In 99% of currently published work on the development of auto contouring, you'll find geometric similarity metrics like dice, surface dice, half-sword distance, etc., repeated between auto contours and clinical ground truth contours. And these metrics have been largely used to even define when auto contouring solutions are clinically acceptable by establishing some threshold like a dice of 0.95. Which would then mean that two contours have a high degree of overlap, and thus something can be inferred about the outcome of using that auto contour on a plan. In a parametric statistical approach, researchers establish some sort of knowledge base from a set of acceptable contours, and then they extract some size, shape, and positional metrics to curate some heuristic rules. Then any new contour can be evaluated with the rules determined from the knowledge base to determine whether that new one might need to review because there is an error in it. And so the problem is that a lot of these geometric similarity metrics have not actually been shown to correlate meaningfully with the final treatment dosimetry for that contour in a standalone situation. So the relationship between geometric agreement metrics and dosimetric impact of differences between two contours is not straightforward. And we've previously published on this topic. We've shown examples like the one on the right, where small contouring differences that occur in large organs like the brain can be largely missed by a metric like the DICE score. Yet with 99% agreement as indicated by that DICE score, a meaningful dose difference can still be found between an auto and clinical contour during planning. In this case, we found an 8-grade difference in terms of max dose between the clinical contour on the clinical plan and our auto contour reported on that same plan. So then we need to think about how do we meaningfully incorporate dose to a QA solution, since there are at least 2 sets of contours to compare and many ways of generating a plan. Van Als et al. Very succinctly summarized the importance of representing dose differences from different plan generations on both clinical contours and deep learning auto contours. Here I'd like to focus your attention on the dosimetric impact of evaluation, or DIE, which uses the dose from generating a plan on deep learning contours to compare the reported differences between clinical and deep learning contours. This method can be interpreted as the impact of not correcting the auto contour on clinical evaluation of dose parameters. And so proper assessment of DIE is very crucial because that's precisely what influences clinical decision-making in whether, for example, an OAR meets its DVH constraints on a plan. So using all of this knowledge, we've put together an experiment that addresses deficiencies in current automatic QA solutions and incorporates new crucial dose information. So the Radiation Planning Assistant currently provides fully automated solutions for head and neck and gynecological cancers, amongst many others. So for these two disease sites, we've created two organ at-risk auto-contouring systems, which we call a primary and a secondary. Now, the primary OAR auto-contour system is meant to be deployed to a clinical user for planning, but we need to make sure that that primary best approximates the clinical contour, or the grand truth, that the clinician would have used in the absence of an auto tool. So we use a verification auto-contouring system to actually validate the primary. And you can think of this methodology as analogous to having a secondary dose calculation algorithm to validate the primary during treatment planning. So then what we want to do is discern whether features calculated between this primary and verification system could predict a clinically meaningful difference between the primary and the clinical contour. The premise is as we deploy our tool, we will always have access to our two auto contour generations, but not necessarily the final clinical delineation. So we need surrogate features to correlate meaningfully with a dose difference between the primary and clinically deployable contour that we predict to know when to flag a potential error to our users in our prediction. And we evaluate this using the purported dose to the primary, verification, and clinical contours from the plan generated using clinical targets, but in this case, the OARs from our primary auto contour system. And if we recall from the concept of dosimetric impact on evaluation, what we're doing here is using the dose from planning on the auto contour OAR to study the impact of not correcting that auto contour on the dose parameters during clinical evaluation of this plan. Notably, what we found is that by using the mean dose difference reported between primary and verification auto contours, it's a big standout metric for predicting a mean dose difference between our primary and the clinical ground truth contour over several hundred OARs we've looked at from real clinical plans. So the mean dose metric can be visualized on both graphs in orange in an experiment to find the optimal threshold for predicting at least a 2-gray dose difference between the clinical and the auto contour. So on the left, you can see this effect for head and neck small organs. Here we include lens, optic nerves, eyes, cochleas, and submandibular glands. And this is for 86 patients. On the right, you can see gyne organs, which include bowel bag, bladder, femoral heads, kidney, rectum, and spinal cord for 50 patients. So where there are deficiencies in employing geometric agreement metrics, we really see the difference with dosimetric parameters. On the right, you can still see that for larger structures like those in gyne, a geometric measure like DICE is still appropriate and performs markedly well for this dose difference. We further tested this relationship by creating logistic regression models that we enhance with synthetic minority oversampling techniques. And we predict again a 2-gray dose difference between clinical and auto contour and found that similar performance can be found when we use our entire feature space versus when we just employ that mean dose metric to predict a mean dose difference. And here we see that effect again for gyne OARs. So looking forward, we hypothesize that these dose parameters are a key to a high-quality automated contour QA solution. With that, I'd like to thank you for your attention and acknowledge the team that makes this research possible.
Thank you, Barbara. Now I would like to welcome Dr. Chris. He's going to talk about, since they are implementing this one, and he's going to talk about the logistic and issues related to that. Welcome, Chris.
Thank you. I hope you can see my screen. So I'm at the other end of the world down south in Cape Town. Thanks very much for joining. I'm going to speak a few minutes about the other end of the RPA and what actually happens before you go clinical. We're not one of the 2 sites in South Africa that has gone clinical, unfortunately, for various reasons, but we hope to in the next week. Similar slide to what Laurence had. According to a Lancet Oncology Commission on Cancer in Sub-Saharan Africa, in the next 15 years, Africa is estimated to need about 5,000 additional LINACs. And of course, to run those, you need staffing and consumables and their major challenges with that. And I'm one of the believers that AI can really make a massive difference in terms of the staffing to improve access to cancer care for many Africans. So the auto planner is in use at MD Anderson, roughly 350 patients a month already. We don't treat that many, but hopefully we'll make a bit of an inroads with that as well. And so obviously when the RPA started about a decade ago, you obviously have to deal with all the, the concerns that people have. And especially in low and middle income countries, where you may have issues like limited internet connectivity. How do you deal with this? Because it's a web-based tool. Turns out it's not that big of a problem, actually. MD Anderson has made this a free for use thing as well. So there are no subscription costs, there are no billing issues. There are, I don't know, Laurence, correct me if I'm wrong, 80 to 100 publications out on this already. So it's a peer-reviewed system that really tries to do things the right way. And so the concerns around the quality of the auto contours and the plans is not really as much as a concern as it could be. Dijkstra et al. At Astro presented again to some barriers on the RPA implementation. And so if you look at the two purple lines, like the dark purple and the pinkish, then power outages, internet connectivity, and paid subscriptions are sort of the major barrier. And it turns out, I mean, you need to run a PC, and once the data is on the RPA, it doesn't really matter if you have a power outage because it's still going to do the number crunching. And so there are really a lot of things that talk, that speak for actually using an RPA. And so in order to do this, you can't just say, well, pick me, I'm going to do this. There's actually quite a rigorous process to get this done. So there's a 4-step process that needs to happen before you can actually become clinical with the RPA. And I'm going to talk about these very briefly. So the first thing is a facility survey, where basically you want to inform MD Anderson, and they also want to know whether you have qualified staff. If a contour has really gone haywire, do you actually have an oncologist to look at this and say, well, hang on, this doesn't quite match, we should do something about this? Do you have the appropriate software and the appropriate treatment devices, appropriate linear accelerators or similar? Is there sufficient physics support? All the things in place that allow for safe delivery of radiotherapy. And once that's in place, you get signed up to the IROC dosimetry audit. So you tell them what linacs you have and what energies you have, and they send you TLDs with setup instructions. You irradiate them to a certain dose, you send them back, they look at them and decide, yeah, you're good, or no, you're not so good. We did find that even if you have fully qualified medical physicists, you have to read the instructions more than once and you may still get it wrong. And unfortunately, if you get it wrong with the TLDs in place, the dose is in, you can't really get it out. But read the instructions more than once. And quite frankly, even if you don't use the RPA, do a dosimetry audit anyway, it's just a good idea. And in South Africa, it's actually mandated once a year. And so when we had our last audit a couple of months ago, we could show them these results and they were all happy. Right. The next thing that they do is kind of a virtual treatment planning system audit. And so I was a little skeptical about this at first, but it turns out actually this is a really useful idea. So the IROC team sends you a spreadsheet with a set of point doses, monitor units, output factors that you have to calculate for all your energies on the treatment planning system. So this doesn't involve measurements. It's all purely a planning system exercise. And you have to fill the spreadsheets in together with your dosimetry spreadsheets and send them back to IROC. And there were actually some really useful recommendations for our hospital. So for example, they stated on our dosimetry, while the worksheets appear to be technically correct, they have several shortcomings that add risk to the calibration process. They stated where they saw the shortcomings, and this was something really useful because you've been doing it a certain way for so long that you may actually be blind to your own shortcomings. And so this was actually a very useful exercise. They also saw, for example, that the dynamic leaf gap and the MLC transmission was lower than expected for a 15 MV beam at our site. And they specifically mentioned this could become a problem for IMRT and VMAT. It turns out we don't use 15 MV for IMRT and VMAT, only for 3D conformal, so it's not such a big problem. But it is just really encouraging that they actually picked this up and flagged it. That's a sign of, that makes me put a lot of trust in the system as well. So this was really great. The report you get is very comprehensive. It kind of looks like this. The field sizes, this is a case of output factors for smallish fields or any fields, and they look at what you get versus what they get for a similar machine, same make and model, and they give you a ratio. And so this was actually a very useful exercise. Also for yourself, to have some confidence in what you do in planning. I mean, it's always a good thing if you get a second pair of eyes to actually look at what you're doing. And so once that was done, you may then ask, well, do we actually know how the system works? And there are some very nice training videos on how to get the patient across, at what point the doctor intervention is required, their end-to-end practice runs. If you need help, they set up Zoom meetings and help you with this. So this was really useful. And so we're at this point now where we're ready to upload our first patient on the RPA. And then we had a very enthusiastic treatment planner who went ahead and planned the patient and said, oh, sorry, you're too late. So now we have to find another one. We did find, just a quick heads up, so it's not all completely smooth sailing. You have to figure out some basic workflow issues. For example, how to get the CT scan from the scanner to the RPA. Your CT scanner may not be connected to the internet, so you may have to have an interface to do that. The radiation planning assistant requires doctors' interventions at certain times to, for example, tick off the contours, and you have to figure out a way to fit this into a busy clinic schedule. You kind of have to figure out what treatment sites work for you. So one of my physicists came to me the other day and said, for whole brain, we may not gain that much with this because it's probably easier just to transfer this to Eclipse and slap 2 beams on and you're done and dusted, rather than actually having to go through the whole process of uploading. But certainly for some sites, I see tremendous savings, and I see a very consistent contouring coming our way, and that's coming our way, and that's really good. So the RPA has been used for treating patients. There's definitely one hospital in South Africa that has used it. A second one where I requested some confirmation, but they didn't give it. But I do think that Tygerberg Hospital will be the next one, and hopefully this year still. And so thank you very much.
Thank you, Chris. Can I ask all the speakers to, on the screen, turn on the cameras? So can you also stop sharing the slides, Chris?
My apologies, stop share.
No problem. So again, the topic is of great interest, as demonstrated by the number of people on this webinar. First of all, there's a lot of good questions. I'm going to direct some questions to each of you. First of all, for those who are attending, the CME points are granted to all those who attend the webinar in full. Since you already registered for the webinar, this automatically registered. Certificates are available within 24 hours. If not, you can always visit iomp.org/certificates and find out. So having that said that, question for you, Dr. Laurence. There was a question about comparison between automatic and manual plans. Were the same number of arches were used? Were both plans deliverable?
Same number of arcs? Was that?
Yeah.
Probably not. So, but we didn't So for the automated plans, we always use 3 arcs so far for head and neck and cervix. And the reason for that is, when you're doing a manual plan, you might aim for less. You might be able to get a good plan with 2, but you can tweak it a lot yourself. The goal of when you automate something, you have to set up a process that gives you the best plan for everybody. So it has to be a sort of global approach. And we found that 3 arcs is the solution to that. So you can pretty much always get a good plan. Whereas manual, there can be more variability. There's more variability from planner to planner too.
One other question for you. The question is, would you say that CTV definition is still an area for improvement for AI outlining? And do you see any particular tumor type where that is particularly challenging?
Yeah. So, I didn't really talk about the targets very much. So, I think AI for normal tissues is basically a done deal. If it's not available, it's just because someone hasn't done it yet, not because it can't be done. For targets, it's a different story. So there's the CTVs that are expansions or what have you from GTVs, and then there's the elective CTVs like pelvic lymph nodes and that sort of thing. The anatomic CTVs, the anatomic part of those CTVs, I guess I should say, comes under the same category as normal tissues in terms of auto-contouring. So there's not much of that around because there's a lot of more variability from institution to institution. So it's more difficult to get the data, but that is a doable process. And what we did here was we had a radiologist recontour a lot of data so we could create those structures. The CTVs, there's a lot of more detail in CTVs, though, like connecting structures and things like that. And we're working on that, but that is not, I wouldn't say we're quite ready with that in terms of actual clinical use. It's easy. I mean, you see a lot of papers on this. What I've learned is it's relatively easy to write a paper, but to actually get something that's good enough for the clinic, that's a different story entirely. So I would say, no, we're not quite there. Same goes to GTVs. I didn't talk about GTVs at all, but GTV contouring, again, we've done some work. Lots of other groups have done a lot more work. We're not there we're there in terms of publishing papers. We're not there in terms of prime time for clinical use, not just yet. But that's coming, I would say.
Sure. This is another question. One question is, a couple of people has the same question. Is it possible to apply to participate and use RPA? What is the process? If somebody is interested, should they contact RPA? And what is that whole process? Yeah,
I mean, you definitely message us. Just there's a website, rpa.mdanderson.org. You can just Google RPA. The main hurdle for us, quite honestly, for us, is just the legal process in terms of expanding from country to country. So we have this tool up and running. It is version 1. We're working on version 2. We have it up and running, but we can't just open it up because we'd inadvertently find out we're breaking laws in all sorts of places. So we need to make sure that doesn't happen. And so the scaling is actually a lot slower than I would like it to be, but because of that, so we're live in South Africa. We are moving into we've initiated the process to check whether we can move into a few more countries, and we're going to scale over the coming years. So unfortunately, this is not ready for prime time in a lot of places just because of the time that it takes to make sure that we are appropriately covering all the bases in terms of legal and regulatory.
This is the general question which I have. This is great for LMIC country, let's say, but how do you assure that somebody started off without solid background of radiation therapy treatment and all those things, they're automatically going to AI, and will they be able to identify, how do they able to identify the errors the AI is giving, whether the AI is doing the correct thing? How do you fix that part?
I would say this is not a tool for somebody who does not know, you have to have, it doesn't get you out of having a real clinical team. This is not that. This is this is something to help your current clinical team scale their efforts. That's the goal. And so, yeah, if you don't know how to review the plan, you should not be using. You're not in the right job. But
no, that's a good thing to know. That's why I just want that to
yeah,
come out for somebody assuming that we can just use this and get over and remove the human from the equation. That is not going to happen. That's what I wanted to stress.
this
that.
is absolutely not that. So you know, and maybe we didn't make the point strong enough, but even if when you have something like this in process, either at all or, you know, there's going to be vendor solutions before long, but you can, even when you have that, you're going to save some time. But some of that time that you save, you absolutely have to invest it in making sure everything is done as you want it. So you've got to put some effort into the QA at the end, because, you know, you can sort of think of the AI as like a resident or something. You know, people make mistakes, while computers make mistakes too, and for a variety of reasons. And so you've absolutely, even once we've put in better versions of the automatic QA, like the stuff that Barbara's working on, even when that happens, you've got to put people at the end, and it's got to be people who are, you know, proper clinical professionals at the end to make sure everything looks okay.
Barbara, a question for you. You mentioned about automation bias. Can you expand on that one?
Yeah, so in the context of auto-contouring, automation bias might mean that you expect the computer to constantly deliver accurate results. And so you might check these contours less or less intensely than you would a manual contour. But like Dr. Court said, what automation is bringing is a new class of risks while it's providing time saving. So manual contours have some errors that you might be used to seeing in the clinic and QAing for. Now, the automatic contour solution will have a different set of errors, like maybe it has a missing slice or a little hole in a place that you can't see, or small boundary misses or extensions that you're not used to. And especially, for example, when we train our models to, for example, give you the full anatomic extent of an organ like a larynx or esophagus, but in your clinical practice, you actually only contour subsections of those OARs when planning. And so there's different types of mistakes and different practices that the auto contouring might give you that you're not used to looking for. And so what I think automation bias means is the medical physicist now has this new role to characterize and understand what are the differences that automatic contouring brings and things that you have to look out for, so that the new role of the physicist is now understanding what else to look for during QA that is not seen in manual contouring, or is a different variation of what you see in manual contouring. So that's why we talked about the risk characterization, so that we don't get stuck with this needle in a haystack problem where we implement this new technology, but then we don't know what kinds of mistakes that we're looking for. And that'll vary from a QA solution.
So Laurence, so one question is, what benchmarks are used to evaluate the performance of AI models in radiation therapy? And the next question is, are these standards in place or is it still in development?
Standards for assessing quality. So, well, that's a massive topic. So there's lots of ways of assessing quality for contours and plans. There's ultimately, you know, there's quantitative ways. So like for contours, like overlap between your true contour, your clinical contour, and your automatic contour, or how much editing was needed, things like that. And Barbara mentioned DICE, which is an overlap metric. And so the challenge with those is it's really difficult to, there's not really a threshold of good versus bad. And so if, you know, for DICE, 1 means perfect agreement, 0 means they're not even touching. And, you know, usually 0.8 and above seems like pretty good, but it really sort of depends where that disagreement is. So it's really quite difficult to, you can get a broad understanding of quality that way, but that's it. And for plans to, you know, dose comparisons, you know, but they, same sort of thing, they give a sort of broad understanding. It's like, you know, DVH can hide some information that's in the 3D dose distribution. So we do all of those things. And then on top of that, my personal opinion is you've really got to get physician review and get the oncologist to look at these things. And even that's difficult because different people have different opinions. So even that's fraught with challenges, but ultimately you've got to have somebody who's good at what, who's experienced in whatever it is that you're trying to do, look at it and say, does this work?
Chris, there's a question directly asked to you. How was South Africa able to scale the legal and regulatory hurdles? I think that's a...
I mean, this process goes back probably 10 years in South Africa. So it wasn't a quick thing. So you often find that first world countries will try and come to developing countries or LMIC countries to help them or save them or something, and then suddenly are very surprised by, the amount of red tape that's in the way. We have a very strict Protection of Personal Information Act in South Africa, so we can't just send out patient data, which suddenly surprises a lot of people. And unfortunately, with MD Anderson, those kind of things were covered quite early on. So the RPA, for example, de-identifies patient data before it starts working on it. And so that may cover some of those legal aspects. But it is a process. It doesn't just happen very quickly. I mean, because a lot of this stuff was done as part of a research project, you have to have, the ethics approval in place from the university. And so it's not completely trivial. But I do think it's worth it. And I really hope that once we start using it, I really hope next week, fingers crossed, that we will kind of figure out very quickly how to slot this into the clinical workflow and actually alleviate some of the clinical pressures. I do see the biggest gain in just contouring time saved. We have a bit of a crunch in terms of oncologists at the moment. The plans that you get from the RPA, I mean, you've got to recalculate those anyway for your machine because those beam models may be subtly different than yours. You may have to re-optimize, but a lot of the work's been done. And so we're still kind of trying to figure out where best to place it. But I do think definitely in terms of the contouring time and the consistency in contouring, I think that's where we'll have the biggest gains.
Thank you, Chris. I think the person who asked the question, I think it's good to start as soon as possible, because it takes a long time to get the hurdles. And more centers start using these things. We can learn from each other, like what you mentioned here, and remove the hurdles. So one question is this is a question. During my time coding on Eclipse, I became acquainted with ES API and binary plugins. What is your advice for beginners and researchers seeking to work on an AI automated planning system? Laurence?
Another massive question. So, I would say from the very beginning, you make sure that your coding is following coding standards, properly documented, properly backed up, all of that. Like, make sure you're rigorous so that when you go back to look at your code, you know what you were trying to do, or if somebody else looks at it. I think that's the rule number one. Rule number two, this takes a long time. So that's, everything takes longer than you think. But if you're doing API coding for your clinic, I would say it's a bit more manageable because you can focus on your particular users and you can develop the things that they particularly want or you particularly want. So it's a little bit easier, but you still need to be careful about the coding standards, proper documentation, and then full testing before you release. And the other thing I would say is, we've done a lot of what they call hazard testing, which is where you intentionally introduce errors and see if people will catch it. And I would say there's a lot of value in that, because we've found when you do you'll do your algorithms, you'll show that your dice or whatever is really good. But once you put it in there, you've got some sort of user interface that somebody has to interact with. And you know, one approach to testing that might be to show the user and say, do you like it? And are you confident that you can use it? And how happy are you? Things like that. And what we've found, we do that, but what we found is people are always confident and they always like it, but they can't necessarily catch errors. So you've got to really think about how you test your interface and that sort of thing. And then final point would be, whatever it is you do, if you're automating it, it's gonna, you know, I'm sure you work at it, you get it so that it's pretty good, but it isn't perfect. And you have to, there is a line that you don't want to cross in terms, you know, you've got to sell this to your user, but you've got to make sure that they realize that, okay, it's great, but it can also not be great. So you know, there's pros and there's cons, and you just got to be straightforward about that, because ultimately the clinical people who are using it have to understand that they have to review it properly and be ready for that.
This exactly brings back to the same solution. Even the airport security scanners, every other time they send some dummies just to check whether the people are catching. I can bring the analogy, similar one. The other thing which I also like is like the human fact in the chain become very critical, and I think quality control become really critical. And in that regard, a couple of things I think the professional societies are beginning to do, like you are involved, trying to provide training or educational aspect for their members so that members can become comfortable. And I think that's one way to scale up this, bringing our practitioners into this picture. So, all right, the other question, there are too many questions. I'm selecting this. I want to apologize for those who see these questions. We cannot answer all the questions because it will take a couple of days a week. So the other question is transfer learning available in the current medical practice and commercial system? Anyone can answer this question. Go ahead.
No, I think is
Okay.
the answer. You know, transfer learning is where you've trained something and then you get some extra data and you sort of transfer to this new situation, the learning. And it's difficult to know how to do this because the quality of the data is key. So there's ultimately, perhaps there will be solutions out there, but you can't have a sort of, it's very difficult to know how to do that. So, because what if your new contours that you think you're learning from are not actually right? So somebody has to assess that. And so we're not doing that for sure. We've frozen everything and then are testing it. And at some point, you know, there are going to be differences in patient populations or other differences that will cause trouble for the algorithms, for the models, for sure. But just sort of like blindly adding that to your data set or doing some sort of transfer learning is not really the right approach, I don't think. But there may be ways to do that, but it's definitely not straightforward. And you know, in terms of research, sure, but in terms of actually letting something loose on your patients, that's a different story.
So this is a general question. What are your thoughts on how do we introduce this AI into the regular curriculum for our medical physics or radiation oncologist, educational staff? And you guys are out there. We're doing, your hands are wet, you're doing the work, but somebody in general want to get to know, because they are getting these tools in their clinic, they need to know what to test, what questions to ask. So what is your thoughts on that? Chris or Laurence, anyone, please. I'd like to get this information out in general.
So I don't really have a good answer here. It's something that I've been thinking about as well, and I haven't come up with a good solution. There are a couple of aspects to this. So I know the IAEA is working on some publications to cover some aspects of this, which should be quite helpful once they are released, hopefully in the not too distant future. The other thing that I've been grappling with a little, but I mean, this may just be a Stellenbosch University problem, is that our red tape is quite cumbersome. So to actually change the curriculum is not completely straightforward. And So we haven't really attempted that yet, but it is on my mind. I just don't have a solution yet. Not a particularly helpful answer, but
It's okay.
that's
Yeah, Laurence.
I would say in many ways, adding these tools to your clinic is not really any different to adding any other tool to your clinic. And, you know, and you might say, oh, we don't understand AI. Well, you don't usually understand a lot of the things that we put into our clinic, quite honestly. And so it's just, it's the same considerations, like does it function? Does it work, right? And what are the risks and what are the workflow implications, both in terms of getting things smoothly integrated, but also when you've made a change to your workflow, it's not always positive. You know, you can introduce something that's negative unintentionally. So I think that, you know, maybe curriculum often don't have enough of that, you know, it might have a lot of sort of routine clinical stuff, but not what do you do when something new comes along? And this is really just something new. And, you know, in a few years' time, we'll have forgotten that this was new in the same way that we've forgotten that VMAT was new sometime, you know. And so it's more, I don't know that it's really introducing AI as a thing into the curriculum as it is as really focusing on what do you do when someone gives you this new box that you've got to do something with.
That's a very optimistic and encouraging answer. No. That's exactly true, because we need to consider this as another tool. And my questions to all the time, how do we equip ourselves to ask the right question? So Barbara, what is your thought on this? Because how did you get started, and what are your thoughts on this one?
So as a researcher, I had to go through 3 stages. One was a deep understanding of the architectures behind auto contouring and then the possible solutions for QA. The second one was to understand the workflow implications like Dr. Cord talked about. So one thing is the architecture of the solution. The next thing is how is it implemented to the clinic and what workflow changes does it bring? But then the third thing, which is mainly the focus of my work, is you have the solution and you have some way of evaluating its performance, but you need to evaluate the evaluation methods for the performance. So talking about the metrics that define whether a solution is clinically acceptable, you know, even with commercial solutions, they don't differ from research auto contouring solutions. We use the same metrics and the same evaluation method. But I think that the role of the medical physicist, because our job is primarily QA, is to focus on the evaluation and understand how it does its work and how our role changes as a result of this new tool and how we evaluate. So, you know, in my courses, even at MD Anderson, the professor who taught imaging science started incorporating deep learning networks as some of his lessons. And that on a small scale in graduate programs for researchers, you can get class exposure to that. But then when it comes to training on what the risks are, I think that that's still a huge space that we need to enter as medical physicists, as developers, and actually create that opportunity so that it's wide accessible. So things like doing it at national conferences, having webinars like these, and we need to standardize the education on risk assessment tools. So I really think that the opportunity space for us right now is to develop a way for medical physicists to understand, you know, we create these solutions, we have certain metrics, but they're not necessarily the optimal evaluation metrics, which then opens up the opportunity for the medical physicist to have a new QA role in understanding how they're going to assess the performance of these tools in clinical practice and how to characterize what these new risks are to be able to look out for them. Because if you don't know what the problem is, you won't be looking for it. And then that's a risk to our patients.
I think that's an excellent answers I got, and thank you. Because that's what I wanted to convey is like, we don't need to be scared of these tools taking us, but we know the basic fundamentals, the medical physicist role. We want to make sure we are ready for this new tool to the whole clinic. And I think I'm going to end this week. Already we are 20 minutes over the hour, but thank you. As you can see, the number of people who joined this webinar today is amazing. More than 1,100 people on this call, and many more is going to review your webinars, because this will be available for recording within 24 hours on the website. And I sincerely thank all of you for taking your time and effort to share your knowledge and information to the wider global audience. Thank you.
Thanks very much. Thanks for organizing and inviting us, and thanks everyone for listening.
Yes, thank you.